Okay, I see we have more folks still coming in from the waiting room, but I think we can go ahead and move to our next slide. Welcome to Connecting for Better Health. Hope everyone is having a nice summer. As a reminder, our coalition set public policy priorities at the beginning of this year in alignment with our vision that every Californian and their care teams have the information and insights needed to make care seamless, high quality, and affordable. Our 4 policy priorities for 2025 are to establish DXF governance and accountability, identify dedicated and sustained funding streams, strengthen social services data sharing, and advance high quality and actionable data sharing. We can move ahead to the next slide with our agenda for today. Have a really packed agenda for today. I'm excited to welcome a few fantastic guest speakers and provide a number of updates. It's been a very busy couple of weeks on the both federal and state policy side. So we're going to dedicate the first half of today's meeting to federal policy developments. We're joined by both Alan Katz from Civitas Networks for Health and Evelyn Gallego from EMI Advisors for some of those federal updates. Before we dig into our California updates, we'll talk about SB 660, state budget, and other bill movement, as well as recent data exchange framework updates. I think we can move ahead to our next slide. Hi, Alan. Welcome to C4BH. Thanks so much for joining today. I think we're going to kick it off with Alan Katz, the summary of the recent reconciliation budget bill and a few other federal updates, and then turn it over to Evelyn. So Alan, thanks for being here today. I'll pass it to you.
Thanks, Stephanie. Appreciate it. And I don't want to take too much time here. I know I tempted to drone on, but as most of you will have probably seen last week, or actually this past weekend, the president signed what's been the One Big Beautiful Bill Act into law. This is the reconciliation package that enacts much of the Republican domestic agenda, and a big part of that agenda is offsetting tax cuts with cuts to domestic programs, and a centerpiece of those domestic cuts is Medicaid cuts. So I have a bunch of detailed slides here, and I can share these with anyone interested afterwards, but I'll just run through sort of some of these key provisions in the order that they come up. These sort of provisions are phased in over the next few years and fiscal years, generally speaking. So beginning in October 2026, ACA expansion states will stop receiving ACA expansion federal matching funds to cover the emergency department costs of undocumented immigrants if those immigrants would have been part of the ACA expansion pool and would have otherwise received ACA matching funds at the 90% level. So instead of 90%, they'll only be reimbursed for emergency care for those immigrants at whatever that state's baseline FMAP is. At the same time, the bill also narrows the qualification for immigrants who can receive Medicaid or can enroll in regular Medicaid coverage by excluding lawfully present refugees and asylum seekers from a list. They were previously included on a list that included lawful permanent residents and a broad range of other categories. So this is a big one, work requirements. By the end of next year, states must face a deadline to ensure that non-disabled adults from ages 19 to 64 with children over 13 in the ACA expansion population are spend at least 80 hours a month either employed doing community service or volunteer work or in some sort of education or training program. There are a bunch of exclusions and caveats to that, but it's generally speaking, it's non-disabled adults with kids who are young teenagers or older if they have children as dependents. States can apply for temporary waivers that run through the end of 2028 And the big part of that is there is $400 million in implementation funding available to that, half of which runs through CMS and half of which will go to state Medicaid agencies starting in fiscal year 2026. Now, to offset the projected cuts in Medicaid that this bill is likely to accumulate over time, uh, Congress and specifically the Senate created a 50 billion rural health transformation program, what they're calling. That's 50 billion total. It's 10 billion a year from FY26 through FY30, and this is funding to support rural two states on a formula basis to support rural healthcare facilities, hospitals, certain clinics, certain behavioral health facilities, etc. And that can be used for a range of purposes, including workforce training, some treatment expenses, or infrastructure modernization, including digital technology modernization. Now, will this completely mitigate the likely coverage, reimbursement, and funding losses as a result of the Medicaid coverage losses that are likely to accrue? Probably not, but something they threw in. Medicaid eligibility checks and redetermination requirements. So by the end of 2026, states need to conduct eligibility redeterminations every 6 months for adults in the ACA expansion population, and they need to use a certain set of um, qualifying sources to verify enrollees' addresses, social security and social security numbers, and vital statistics like this using the Social Security Administration's master death file and the National Change of Address Network and other sources that are either mentioned in the bill or that will be approved by the HHS Secretary. And this gets another 75 million in implementation funding for this to CMS starting in FY26. Moving on past FY26, um, is there a way to get to the next slide here? Okay, yeah. So moving on to FY27, you have a big potential budgetary crunch for states here. So the SNAP cost sharing provisions start in FY27. Um, so starting in FY27, states have to pay 75% of the admin costs associated with SNAP. And again, SNAP is the Supplemental Nutrition Assistance Program. This is food stamps. So instead of paying 50% of administrative costs as they do currently, states have to cover 75% of the administrative costs associated with food stamps. And then beginning in FY28, they need to pay between 5 and 15% of the benefit costs for the SNAP program in their state, which is a huge multi-billion dollar, in most cases, obligation that's being foisted on states from the federal government. The exact percentage of benefit costs they'll be required to shoulder will depend on the state's payment error rates. Although there's at the last minute they built in sort of a delaying mechanism for certain states with high error rates that will be exempted for a longer period of time. But the reality is the majority of states will have to pay between 5 and 15% starting in FY28 if there isn't further legislation that would delay or address this. Um, Home and community-based service waivers within Medicaid. Starting in July of 2028, states, there'll be a little bit more flexibility within the 1915 C waiver program, one of the demonstration authorities under Medicare, for CMS to approve state plans that allow Medicaid enrollees that don't currently receive what they call an institutional level of care, which means a level of care comparable to what you'd receive in a full-time residential nursing home, would allow a greater range of people to receive home and community-based services using federal dollars, provided that the waivers are still budget neutral and the waivers impact is not to increase wait times or delays for people who are in nursing homes receiving that higher level of care. That's something that HHS needs to issue additional guidance on. They have some time to do so, but it's important to note that this was included in the final version of the bill. And there's also 50 million in CMS implementation funding for promoting waiver flexibility and building out this program beginning in FY26 and 100 million that will be distributed to states starting in FY27. By October 2028, you have new Medicaid enrollee cost share requirements that will kick in. States will be able to impose a maximum of $35 in cost sharing for on ACA expansion enrollees who receive certain services. Those services exclude behavioral health. They exclude primary care in some cases, and there's a bunch of other caveats, but generally speaking, states will be able to impose up to $35 in cost share requirements for a bunch of services that are previously free of copays for those enrollees under the ACA expansion population. And then this is another big issue for states in terms of their budgetary ability to cover and continue to enroll large shares of the Medicaid population. Um, provider Medicaid provider tax adjustments will begin from on a sliding scale from or on a sort of a annual decreases from the current threshold from fiscal year 2028 to fiscal year 2032. The ACA expansion states will see their safe harbor limit, which is currently 6% of statewide provider revenue that's allowed to up to 6% taxes on statewide provider revenue that's currently allowed. That'll be dropped by 0.5% each year until it hits 3.5%. And this will significantly, really meaningfully constrain the ability of states to finance their state shares of Medicaid matching funds for in expansion states because provider taxes are currently a major source of financing for that state level match. And then in those 10 states that did not expand Medicaid, um, their thresholds will not be reduced, but they won't be able to increase or change their current provider tax rates at all, which means the funding they will get through provider taxes will decrease over time as the Medicaid population changes or increases. So that's the sort of the timeline of the major provisions affecting Medicaid and other state budgetary social service issues that will, we expect, certainly as Civitas representing HIEs around the country, APCDs, RICs, QIOs, we expect the ripple effects of um, these cuts not only on state budgets as well as on providers themselves to really ultimately be felt in terms of the resources that these partners have available to support health information technology infrastructure, to support new services and expansions versus retaining existing services, and to support efforts on important priorities like data standardization, as well as partnerships in building referral systems on the state and federal level, and in outreach for non-medical drivers of health and related standardization programs. So this is going to have a restraining effect on a lot of that activity. It'll vary state by state depending on state's ability to step up and plug some of these holes, willingness and ability, but ultimately there will be a large scale impact over time. And, we're working with our members and our partners to try to mitigate this and plan in a contingency-based way as much as possible. And then the
Hey,
last,
Alan, on this timing piece, so I think all of us are deeply concerned about the hugely devastating impact for state financing on administering health and social services programs. It looks like that quite a lot of that is coming in fiscal year 2027. Is that accurate? More so than fiscal year 2026?
yes, that's accurate.
Okay.
The SNAP cost share and in practice the work requirements. But keep in mind those are deadlines, and so some
Mhm.
states can certainly jump the gun and begin planning and rolling out their adjustments to meet these requirements earlier, right? A lot of this will depend on the state. So for work requirements or community engagement, as they call it, it has to start by early 2020, last day of the year, 2026 is the last day. The next day it has to start unless they get a waiver, but states can and probably are planning for this already. So it does not necessarily, these are sort of deadlines, but states can and will be rolling out a lot of these changes. The federal government will be rolling out those changes beforehand. Some things that were left out of the big legislative package on the final slide here. There's an, uh, well, hold on, if we can, yeah. So there was a lot of talk about a state AI regulation moratorium. This was in the House passed version of the bill, would have banned any sort of state AI regulation for 10 years. Ultimately, there was a lot of Republican pushback to this in the Senate, partly based on Senate rules, partly based on genuine reluctance to enact this and understanding of some of the consequences would be in banning states from regulating AI. This was ultimately struck down in the final bill. There is no AI curb on regulation in the current bill. This was also one of the relatively few areas where you saw an effort by Republican stakeholders, governors, others really kind of push back on this and try to get this piece knocked out, which they did. There was in the House passed version of the bill and in the initial Senate version of the bill an FMAP immigrant penalty for those states um, which were ACA Medicaid extension states and used the standard 90% FMAP. Um, you help allowed up to you, or I should take a step back and say there are currently 14 states in DC in the country that use state dollars to finance Medicaid coverage for various categories of undocumented immigrants. Some states it's just children and pregnant mothers. Some states it's the whole population. Um, in the House passed version, in the initial Senate version of the bill, would have penalized those states for doing that out of their state funds by cutting their Medicaid ACA expansion FMAP from the standard 90% down to 80%. That provision was ultimately left on the cutting room floor, so would have been an additional further budget crunch to a lot of states that has been dropped from the final bill. There was also finally, there was in the healthcare space, especially for hospitals and hospital partners, disproportionate share hospital reductions were supposed to be delayed again. They've been delayed repeatedly. There's an ACA requirement that DSH payments be cut over time. That requirement has been delayed going back years and years in various pieces of legislation. I think as far back as 2014. Um, there was supposed to be another delay again to push it back to 2028. That delay was dropped. So we are disproportionate share hospitals are going to see their payments cut starting in FY26. So there may, in future legislation, in the FY26 appropriations, in some other legislation, they may try to include those DSH payment reduction delays again. Now, again, this bill is passed, it's in law. Looking ahead, members in both the House and Senate are making noises about a second reconciliation package in the fall that will make further cuts potentially to Medicaid and or other social service programs. And this is still in the discussion stage. It reflects some of the agreements that were struck on the Senate and the House side with some of the most conservative Republicans to pass the bill because they were upset the deficit the how this bill explodes the federal deficit without making enough domestic spending cuts to offset it. So there is potentially another reconciliation package in the works for the fall. There's also the FY 2026 appropriations um, process, which is now kind of started while the one big beautiful bill was in the works, but is now beginning in earnest. There's not a lot of collaboration on that so far from um, between the House or between Republicans and Democrats. Unlike this reconciliation package, which used the reconciliation process to avoid the filibuster, annual appropriations cannot don't use the reconciliation process, and so Senate Democrats can filibuster, which means Democrats have some leverage in negotiating. The end product in annual appropriations has to be a negotiated both side product, and so that really hasn't begun in earnest yet, and we'll have to see where that turns out. Current government funding runs through the end of the fiscal year. Beyond that, if there's no deal, which is the end of September, we could be facing shutdown, drama, and dysfunction again. And now, beyond the legislative stuff, I want to make sure we have enough time for TEFCA. So one thing we have seen in the last 2 weeks is that after a long period on the federal level of sort of uncertainty and lack of real movement from the Trump administration, what are they going to do with TEFCA? Are they going to continue the Biden administration's approach? Are they going to effectively are they going to de-emphasize TEFCA? What are they going to do with it? What are they going to do to the existing regulations? Um, we've gotten some really new and clearer signals from the administration that TEFCA is moving forward. The Trump administration is embracing TEFCA as a trusted exchange framework, not as an exclusive trusted exchange framework, but as a national mechanism and vehicle that will operate alongside other national networks and entities that operate on the state and regional level, which is important, especially for us at Civitas, given that we represent state and regional health information exchanges and other stakeholders that are not necessarily TEFCA, uh, maybe involved in TEFCA, but that are not predate TEFCA, have capabilities outside and in many cases beyond those of TEFCA to date. And so we're hearing inclusive signals from the administration on TEFCA, which is really good to hear. The new ASTP ONC director is Tom Keene, a doctor and a software programmer who worked in HHS during the first Trump administration, including a stint in ASTP ONC, or ONC as it was called then, and who has since worked in Maryland's health administration, with Maryland's excuse me, health information exchange, and has a lot of familiarity with the HIE landscape and with a lot of these policy issues in particular. We've been at good, positive discussions with him, and we're looking forward to continuing those discussions and that development. One of the big things we're looking at in the next few weeks will be the elections and the setting up of the TEFCA governing board. In the past few months, TEFCA has laid out in a kind of a provisional way its QHIN, its sort of governing structures that were put in writing in theory last year, but that had kind of been put on hold until earlier this year. There is a TEFCA QHIN caucus with representatives from each of the QHINs, and there's a TEFCA participant and sub-participant caucus with representatives from participants and sub-participants in TEFCA that are connected to TEFCA, including health systems of varying sizes, as well as health information exchanges. Within those two caucuses, members will be selected to serve on the TEFCA governing board, which will oversee going forward changes to the framework and a lot of the TEFCA policy development and engagement with outside stakeholders. So that's something we want to watch intently in the next few weeks as the TEFCA governing board comes together. And then beyond that, the big news from TEFCA is also that they have put out their new QTF, which is QHIN Technical Framework draft version 2.0. This primarily is something that affects QHINs rather than HIEs or healthcare providers necessarily, but it expands the QHIN query or function to include QHIN sort of direct query through QHINs to include specific participants and sub-participants, and therefore kind of enhances the functionality of QHIN exchange in that way. That draft is open through July 28th if anybody would like to submit public comments.
Thanks so much, Alan. And we're bringing on Evelyn in just a moment as well for some further TEFCA conversation. Before we leave the reconciliation bill piece, though, I'll pop in the brief statement that our Department of Healthcare Services released on Monday in California. emphasizing the risks to the health stability and economic security to California because of this bill. And we're waiting to see further analysis, right? I think we'll get a lot more in terms of projected financial outcomes for various states like California, projected disenrollment. But like we talked about, I think at our last Connecting for Better Health meeting, right, the Kaiser Family Foundation estimates and a few others from prior versions of the reconciliation bill, not necessarily this final version that was signed, but the prior versions estimated around 1.7 million Californians losing their health coverage because of these. So we'll continue to aggregate and share out those analyses and projections as they come out for California specific numbers. But thank you so much, Alan, for being here. Really appreciate the updates, and we hope that you can stick around for the rest of the conversation because we're going to keep talking about TEFCA over the next few minutes.
Oh, absolutely. Looking forward to it.
Okay, Olivia, you want to bring on Evelyn?
And Stephanie, should we use the chat for questions? Alan, if you're going to be sticking around, let's use the chat if anybody has questions for Alan, just we have so much to get through.
All right, with that, we are excited to bring on Evelyn Gallego, who is the CEO and founder of EMI Advisors. They've been great partners in our DXF Community Sandbox work, and she's located in DC and is with us today to break down some of the updates to the ASTP ONC Health IT Certification Program. Evelyn?
Thanks, Olivia, and hello, everyone. So happy to be back and giving a debrief on what's happening within the federal landscape. And thank you, Alan, for that thorough overview of the new bill and TEFCA update. So my first update is very straightforward. It's just announcing that the approved 2025 standards are now available through ONC's Standards Version Advancement Process, or SVAP. And so there are 4 new approved standards listed there. And actually, if you go onto the website and the hyperlink is there, does a thorough review of where they're allocated. So of course, we're moving on to version 5 right now of USCDI. And again, these are the data standards for terminology, data classes. So they're not the content or the transport standards. Then we have an updated version of the FHIR US Core, which is very critical for all the work we do, in particular around the open APIs, and we'll talk about APIs next. There's an update to HL7 CDA. So the CCDA, a lot of our work still continues. A lot of the data exchange still happening within CCDA document templates. And then 2 updates to the QRD. These are the quality measures. So there's the CMS QRDA implementation guide for hospital quality reporting that was updated last year, as well as the implementation guide for eligible clinicians. So more detail, thank you, Olivia, for including them there for your awareness. And always I have to put a plug in as a reminder, these are open standards available for the public at large. So, and part of it is that they are, that's why they are called out in policy and recommended, because they are open standards and they support interoperability. Okay, next slide. All right, so for the latest announcement, piggyback on the bill and the focus and why there's a lot of this work going on around reducing cost, deregulation. So for those that have not already heard the news, on June 30th, ASTP ONC released a new notice, enforcement discretion notice, for real-world testing for condition and maintenance requirements of certified health information technology, or CERT. Very much within the realm of reducing administrative burden, reducing regulatory burden on private industry, right? So again, a reminder of ASTP's role, and this is how I ground they are very much, from a regulatory perspective, focused on transparency. So a lot of their oversight is really to support transparency around data exchange, and that's how they regulate the certified technology. And I say in contrast to the FDA, Food and Drug Administration, that regulates for safety, food safety, drug safety. So they end up, so those are the requirements within both. So prior to this notice, so as part of the 21st Century Cures Act, there was a requirement for ASTP to oversee and to require real-world testing or RWT results be shared annually with ASTP, with the criteria listed here around care coordination, clinical quality measures, view, download, and transmit to third party, public health, APIs, and transport methods and other protocols. So as the notice was released, was saying, we no longer need to see your, so if we move on to the next slide, the notice now states that there is no longer this requirement. So the notice includes the impacts that effective of through next year, a developer is not expected to submit an annual real-world testing plan for the 2026 real-world testing year, and is not expected for 2025 either, with the exception of the API. So basically, ASTP is saying, you can go test, but we really only want to see the results of APIs. So of course, this has a lot of impact because, as we know, as much as we, ASTP and CMS are promoting FHIR-based exchange, we know the majority of testing and actual exchange is not yet fully FHIR-based, right? And even with TEFCA as well, we're not there yet. So there is implications for this. So if we move on to the next slide, I do want to highlight some really key points. The source referencing this is from, many of you already know who Josh Mandel is. He published a really good blog on July 2nd, really highlighting the impact around this new policy. So really, here's my thing, what I grabbed from looking at it, but what he does a nice job of actually drilling down on examples. But with this, like saying, again, we know what the real world, what the market looks like now for real world exchange. And so not having these requirements, really, this is where transparency, there is no more transparency, right? So we lose that as a market. And you lose what he does a nice job. You lose visibility into the performance of asynchronous multi-party transactions. And we know this is what exists in the world right now. There's multiple ways that data is being exchanged and shared and to test that and validate it. So, he lists them all here. We lose visibility into EHR to pharmacy network data exchange. Again, not FHIR-based. These are non-APIs. Inpatient to ambulatory transitions, legacy system interoperability. So this one I'll hone in. We know a lot of legacy systems are still being used in the field and data being shared with them. So right now there's going to be no transparency on that. The direct messaging network. So right now, that's not of interest. Public health reporting and data mapping, patient portal usage. So one of the requirements is being able to track, download, view, transmit criteria. And we know not all of those solutions are exchanging data using APIs. So that's also a gap that will be forthcoming. The other one is around EHI export functionality. So that Josh had mentioned, and others, I did look through several other blog posts and what the market was saying, that that no longer will be available. And we know a lot of not only vendors as you look across, but health systems, other technology providers really look at this data, saying what's working, what's not working. So right now that export is no longer there, and I think too, as we look at it from a strategic perspective, there's a lot of insights in these final reports, and I wasn't aware of that. So Josh had alluded to the EHR product strategy and adoption. Josh and others also had noted that with this new policy, we really move towards more of a checklist level, right? So there's a risk of vendors, if you are not required to report on things, you won't, or you'll do the minimal, right? And they're afraid that with now just having one reporting on API testing, they'll do it at a very high level that there really is no insights that the market overall can glean from them. So I think, again, I'm not a vendor myself, but it was very very insightful to hear from other vendors in the field of how this would impact them or will impact them. I know also from others that they have there's been significant investment by Certified Technology in developing these reports, right? So there's a loss there as well. But again, the purpose of this really ties into reducing, minimizing regulatory oversight and burden on the industry as they try to be compliant with government regulations. So I'll stop there, see if there's any question. Okay, no, not for me.
Thank you,
Yeah.
Evelyn. Oh yes, sorry. Was someone coming off mute? No, I don't think so. No, thank you for the detailed overview. I'm not, just to keep us on track, I'm not sure we have too much time for Q&A. But if you're able to stick around, maybe we can continue answering questions that come up in the chat.
Happy to.
All right, thank you. And I think moving along, Stephanie, you want me to quick cover this?
Yeah, I think in the interest of time, we can just put a link to the chat, but if you want to just share what happened yesterday.
Perfect. So yesterday the Senate Health, Education, Labor, and Pensions Committee held a hearing on the topic of securing the future of healthcare, enhancing cybersecurity, and protecting Americans' privacy. We just popped a link in the chat where you can view the recording and welcome you to come back to our slides to look at some of the takeaways. And I think with this, we're able to move into some of our California updates.
Yes, just really quickly, just a reminder that Governor Gavin Newsom signed the budget on June 27th. This is a follow-up of our presentation by Max Perry from Aliados. We know that there's a lot of additional details that are still being worked out at the state level, and we're staying tuned for any of those updates. And then we are also waiting to hear about the federal reconciliation bill and how that may have monetary impacts on California state funding. And I know that that is really top of mind for many of our initiatives and partners, so we are closely monitoring that. And then just a more positive update on SB 660. It has passed the Assembly Health Committee. Thank you to all of our partners that came to the hearing last week, and a special thank you to Max and Jason Moriarty, Max from Aliados, Jason from Partners in Care, for giving a great testimony at the hearing. The bill will be heard next at the Assembly Privacy and Consumer Protection Committee next Wednesday, July 16th. Connecting for Better Health is also going to be focusing on storytelling this summer as the legislature is going on their summer recess. So we have a couple of examples already on our website. Maybe Olivia, you could put a link in the chat. And if you or any of your partners are interested in sharing your story about data sharing, please reach out to us. We know as a coalition the power of storytelling and how it really paints a picture on how and why data sharing is really important and how it benefits the lives of the patients that are being served in California.
We have a short list of folks, especially those of you who joined us at our Advocacy Day in March, that we will be reaching out to share your stories. So please look out for outreach from us. And yes, really encourage you all to get in touch with us if you'd like to share a story. We continue to hear from legislators in Sacramento that the most impactful thing we can do as a coalition is provide real world examples and human-centered stories of the impact of data sharing. So thank you, everyone who continues to engage in these efforts.
And we'll do all the heavy lifting. We really just need you to raise your hand and we will do the interviewing. We have our communications team that can develop the drafts and work to be able to get it right. But yeah, we would love to be able to let's put our goal as double the number of stories that we have out there today over the course of the next few weeks. So please reach out. And all of us have something. We either have a personal story or a professional story. We can use them all. So thank you.
Thank you, Timmy. And then moving along, we just have a few spotlight articles that we wanted to highlight. AB 512 regarding prior authorization was heard in the Senate Health Committee yesterday and was passed to the Senate Appropriations Committee. It has been also amended to include concurrent authorization requests along with prior authorizations to the requirement that health plans and insurers need to follow to approve of all requests in under 48 hours rather than the standard 5 business days. SB 250 will also be heard in the Assembly Appropriations Committee soon, and it has been amended to require that DHCS we'll need to annually update the provider directory that lists all skilled nursing facilities contracted with Medi-Cal plans. And we actually have Katie Andrew on from the Local Health Plans of California, who is going to provide a quick update on AB 618, authored by Assemblymember Maggie Krell. So I'll pass it to you, Katie.
There we go. Thanks, Maya. Appreciate it. Happy to be with you all. Thanks for the invitation. Really quickly, because I know time is important here. But AB 618 has cleared a number of hurdles, and we are currently in Senate appropriations and have been placed on the suspense file. So we are anticipating that the suspense hearing will be the week of August 25th. And so in the meantime, we are doing our due diligence in terms of trying to persuade members of the legislature and the committee that that the bill, although the department, DHCS, has flagged that the fiscal would be in the hundreds of thousands of dollars, that we do not anticipate that is an accurate estimate of the cost of this bill. And so, and for a few different reasons, there are a number of venues in which the department is already engaging with county behavioral health and Medi-Cal managed care plans. And so we are beating our drum about how those venues those already existing venues could be utilized in order to reduce the cost of this bill. They also, in their fiscal analysis, had a line in there about unknown costs and cost pressures to the general fund and Medi-Cal due to the implementation of the data sharing requirements, which we also feel that may be a little bit of fluff, only because there are already expectations put upon plans and behavioral health to do that data sharing. But where we get stuck is providing that sort of legal cover to county council that this is allowable and the reasons it's allowable. And so needing to which is the whole impetus for the bill, right? So needing the state to clearly define and be directive in what data sharing should occur, can occur, and when, and in what format. So that work is ongoing. And then lastly, I will just add that the bill has been amended. So you will, and those amendments are in print that occurred in the Senate Health Committee. And so those amendments actually make clear the involvement of the Health and Human Services Agency, and specifically also calls out the data exchange framework, just to ensure that whatever guidance is put out by the department, obviously informed by a stakeholdering process, will also keep in mind and be mindful of the data exchange framework and the interplay there. So wanted to share that with you all too. And so the work continues. And you know, we also just as a well, it is important. We know that the department is working actively on guidance for county behavioral health and plans around behavioral health data sharing. And we don't have any insights at this point into what might be included in that guidance. But our perspective is that if this bill should get stuck in the Appropriations Committee, or if we make it to the governor's desk, if it is vetoed, which as you all are aware, there's a similar bill that had been vetoed by the governor. with the directive for the department to work on this. So if that should happen, we still feel like this would be considered a success, because one of our goals was really to push the department in the direction of providing that directive guidance. And so hopefully the bill does pass, and we have this in statute and a statutory mandate for the department to do this work. But in the off chance that it's not, it is nice to know that work is happening on some level at the department, and we are very eager to learn what might be included in that guidance. So I'll leave it there, but happy to answer any questions you all may have.
Thanks so much, Katie. And I just want to thank you and LHPC and the committee as well for the amendment around the data exchange framework inclusion. That was something that many folks on this call felt like was important to see. So we're really grateful.
Yeah, absolutely. We were happy to take it. Thanks.
Thank you again, Katie. And then just as a quick reminder, the legislature is going on their summer recess from July 18th and then reconvening on August 18th. And I will pass it over to Olivia, who's going to give a few updates on the DXF.
Thank you, Maya. I think two key updates that we're tracking at C4BH with the DXF. The first one is the proposed amendment to the technical requirements for Exchange PMP. Thank you to those who were able to join our office hours to discuss the PMP and C4BH's proposed response. As a reminder as well, public comments are due on July 21st. And C4BH is aiming to share our final public comments after finalizing them with our advisory group the Friday before. So I believe that will be Friday the 18th in the morning. We'll make sure to get those out to people. And we encourage you guys to repurpose and use those comments to support your own comments as well. At a very high level, the proposed amendments include a lot. One notable one would be to extend the event notification requirements to skilled nursing facilities beginning in 2027. There is additional proposals as well around establishing minimum data content and also format standards for event notifications, including aspects like notifications being supported as both human and machine readable formats, and then also including minimum required data for emissions and discharge notifications. On our next slide, I'll just highlight some of the direction that we're going in with our C4BH comments. We appreciate the minimum data being established for the emissions and discharges, and would suggest as well that discharge to location and patient preferred language are included as well, as we've learned that they're very essential for care coordination from our DXF Community Design Studio findings. We also will be speaking to the need for ADTs or for event notifications to be really meaningful and actionable, and to include the data that they need for participants to do the follow-up that they need. So, encouraging these event notifications to not just, stick with the minimum data, but to add additional data elements as needed, depending on the use case. So, for example, a discharge from an ED versus a SNF might have some additional data elements that you include. We also would like to propose the idea of expanding to allowing or requiring transfer event notifications to be supported when they are requested from participants, because we've learned that through our design studios as well, that sometimes a transfer might mean that a patient's moving to an outpatient clinic or moving to a SNF, which could get missed if not sent as a discharge. So encouraging that to be supported as well. And then also looking to the idea of using the QHIOs as an area to establish some standardization. For example, perhaps the QHIOs could establish a standard roster format that they use to share rosters among themselves, and then also helping to define what a human readable format might mean, and looking to the QHIOs there. And I think, as we continue to work on these, definitely encourage folks to reach out if you have any questions about the proposed amendment. We'd be happy to chat and share more about what we're thinking. And I think one other update that we're tracking around the DXF is looking to the Technical Advisory Committee. And they have their final meeting right after this meeting starting at noon. This group has been convening 4 meetings around consent management and looking to develop recommendations for the coordination, collection, sharing, and then use of an individual's consent as it is applied to exchanging health and social services information under the DXF. Key themes from our last meeting is that there's been support for a simple and easy place for individuals to manage and update and even to revoke their consent preferences, even if consent is held in multiple places. Folks have been discussing the need for different consents for different types of use cases, for example, behavioral health, reproductive health care, justice-involved use cases. So looking for some flexibility there. And then additionally, when it comes to the question of, where can we start? There has been support for beginning with a consent model that is scalable and one that focuses on starting with more established use cases and where the maturity of data standards exist, and then getting those wins and then scaling up from there to apply to other use cases. And I think we're doing good on time, so I'm going to invite Elena. I think our friend Elena from San Diego 211, who is one of the committee members. If you'd like to share any thoughts, would love to hear your reactions. Oh, and I think she might have dropped off, unfortunately. So we'll make sure that we pull people together for a debrief once the full meeting series ends later today. And I think with that, Stephanie, I'll hand it over to you to wrap us up on our news, events, and announcements.
Sure. Okay, 2 new publications from the California Healthcare Foundation this week, both focused on data exchange. We'll add both to the chat. The first is a report focused on efficiency and cost savings due to strengthened data exchange. The second is a blog or an article authored by CHCF CEO Sandra Hernandez related to data sharing. So we'll put the links to both in the chat. Would love for you all to check them out, read them, share them with your networks, as we will as well on our social media channels and newsletters. And then the next slide, we wanted to share a new resource that the C4BH team has created that we'll add to the chat as well. This idea, I have to give huge credit to our health center partners who brought this to us as a tool that would be useful in explaining the impact of data sharing to a broader audience and really thinking about our communications tools beyond the folks on this call or in our regular conversations that maybe live in the California Data Exchange Framework day in and day out. It's called Shared Data, Shared Purpose, and provides a bit of a city or town visual to think about how different entities and organizations benefit from strengthened data sharing. So again, we hope that this is helpful to you in your work. Please feel free to use it however might be helpful. It's also something that we're looking forward to bringing with us to Sacramento in terms of a policymaker education tool. Olivia or any other folks on the line want to add thoughts, questions, or ideas related to this?
Not much to add. I would just say that I think by getting really concrete with the real world examples, we've heard from partners that that's been a really helpful tool to help engage folks that maybe aren't as tuned into health IT, but it is really a part of their daily work. So the more that we can get clear with examples, it'll help drive these conversations.
And I just love being reminded that all of us that do this work day in and day out, that there's so much education needed to be done. And that I just am always, again, reminded that most of our colleagues, peers, family members, friends already think that this data is moving and there to support the journeys that they're on. And we have to be constantly reminded to be able to tell the story. So this has been fantastic. And thank you to our advisory group as well. That really helped to edit it over time.
Moving on to our next slide. We are partnering with the Archstone Foundation for our second Data Exchange Framework Boot Camp with the Archstone Foundation focused on organizations that serve older adults. It will be an older adults focused boot camp held virtually on July 22nd from 12 to 3. We would love for folks to share this with your network, any interested organizations or partners who work with older adults and also caregivers in California. We're really excited to partner with the Archstone Foundation to host these boot camps and also develop a DXF community design studio later this year, informed by the use cases that come from these 2 boot camps that will deal with issues related to dementia diagnoses and other data sharing challenges faced by organizations serving older adults in California. So please share the invitation with individuals or organizations that might be interested in attending. And I think that's our last one for today. We can go ahead and just skip forward to webinars and events, upcoming events. As always, please send us your announcements, your webinars, your conferences, speaking opportunities, and we'll be sure to share them in our newsletter and our meetings. With that, Timmy, I'll hand it over to you, but I think we can wrap up for the day.
Absolutely. And so we will keep you all posted on SB 660 with the Privacy Committee next week. It's a big milestone to get it out of committee and over to appropriations, which then, as we were reminded, we need to get it out of appropriations and onto the governor's desk. So we'll keep you posted. And thank you for all of you that have been supporting us as we've been moving through the bill process. Enjoy your summer. And we are, as you see, we have access to such great individuals who are experts as they're tracking and doing this full time. So if you have any questions, reach out to us and we will do our best to get answers, whether it's on the budget, impending budget, or pending budget work that might be in the future. And then also, all of the work that we're doing to be able to support data sharing in the state. So thank you for the team, and we'll see you all soon. Yes,
Thanks,
Binder.
Olivia.
Thank you, Olivia.
Yeah.
Yes,
We are
so we
not
are taking a
meeting.
break. Go ahead, Stephanie.
I was going to say, we're taking our brief summer recess. There will not be a second meeting in July. We will see you all in August.
But we'll be online. All right. Thanks all. Take care.